Welcome to the Hospital Medicine Unplugged podcast. Today, we are taking a deep dive into, well, what is arguably one of the most high-stakes, low-prevalence vascular emergencies we see in hospital medicine, acute mesenteric ischemia, AMI.
Right.
This is essentially a sudden, really life-threatening collapse in the blood supply to the gut. It demands instant recognition, instant intervention. Now, it is rare. We're talking, 0.09 to 0.2% of acute admissions, so not common.
No, not at all.
But that rarity hides a truly devastating, extremely time-sensitive threat.
And that threat, that's exactly why we need to focus on standardizing how we approach this. Because the diagnosis can feel chaotic, but the window for intervention is just painfully small.
How small are we talking?
We're talking about mortality rates often exceeding 50% if it's untreated, or even if treatment gets delayed by just a few hours.
Wow.
So for you, the listener, our mission today is really to cut through some of that clinical ambiguity. We want to distill the latest evidence. We're pulling from contemporary reviews, some very recent research from 2024 and 2025, and crucially, guidelines from groups like the World Society of Emergency Surgery.
The goal being a clear, standardized protocol to hopefully dramatically improve outcomes.
Exactly. We need a system.
It feels like we almost have to treat this like an abdominal stroke, you know?
That's a perfect analogy. Time is bowel. Diagnostic delays, they aren't just a failure of process. They translate directly into higher morbidity, higher likelihood of massive intestinal resection, and frankly, death.
So standardizing care is key. When that rare presentation does walk through the door or more likely develops on the floor, the response needs to be immediate, coordinated.
Yeah, it really requires shifting away from relying only on those late physical signs, which we'll get into. We need a rigorous process, something based on risk stratification and critically rapid advanced imaging.
And part of that is understanding that AMI isn't just one thing, right?
Precisely. We need to start thinking about AMI not as a single entity, but as a group of 4 distinct pathophysiological conditions. Each one needs a tailored approach.
Okay, let's unpack this then, because AMI isn't a monolith, it's a spectrum, like you said. Understanding these 4 primary subtypes is essential because the treatment pathway, medical, endovascular, open, surgical, it changes completely based on the cause.
Right, so let's start with the most common one. This accounts for about half, maybe a little more of all cases. Type 1. Acute arterial embolic mesenteric ischemia.
Embolic. Okay, so as the name suggests, this is usually an embolus, a clot that's traveled from somewhere else.
Almost always the heart, yeah. So you're thinking about patients with really significant underlying risk factors. Unmanaged atrial fibrillation's a big one, or recent large myocardial infarction, maybe with a ventricular thrombus that formed. That clot breaks off, travels downstream.
And lodges where? Usually the SMA.
Most often in the superior mesenteric artery, yeah. Typically distal to the middle colic artery takeoff.
And the key word here you mentioned is sudden, right?
Absolutely sudden. Because the occlusion is abrupt, catastrophic, there's basically zero physiological time for the body to develop or utilize any collateral circulation, which is what normally protects the gut to some extent.
So no backup system ready?
None. The result is instant severe ischemia, and it progresses incredibly rapidly to full thickness, transmural necrosis. The clinical picture reflects that. Abrupt, just catastrophic onset of pain.
Okay, so that's the embolus. Let's contrast that sharply then with the second type, acute arterial thrombotic mesenteric ischemia. That's 15 to 25% of cases?
Right, around that range. And this is a fundamentally different mechanism. It's built on a foundation of chronic illness.
Chronic illness meaning atherosclerosis.
Exactly. Here, the acute event is a thrombosis, a clot forming right there, but it's superimposed on severe, long-standing atherosclerosis. Usually affects the origin of the SMA, right where it comes off the aorta.
So these patients already have underlying vascular disease.
Oh yeah, diffuse systemic vascular disease. You're looking for hypertension, hyperlipidemia, maybe a history of previous atherosclerotic events like coronary disease or peripheral artery disease.
And their history is the key differentiator here, isn't it? Because they've had this progressive narrowing maybe for decades.
Precisely. Their bodies have had time to develop extensive collateral circulation. Nature finds a way sometimes.
Right.
So when that final thrombotic occlusion happens, the presentation is often, different. It's frequently an acute worsening of chronic symptoms they might have been having for months or even years.
Chronic symptoms like
postprandial abdominal pain, pain that reliably starts 15, maybe 30 minutes after eating. This often leads to unintentional weight loss because eating hurts.
And that classic food fear, right? Or abdominal
And
angina.
that's exactly it. They subconsciously or consciously avoid eating to avoid the pain. Now, while those existing collaterals can sometimes slow down the progression of the acute ischemia compared to an embolus, the underlying disease is often more complex. It might require more extensive revascularization once you confirm the acute event.
Okay, so that covers the two main arterial types. Let's move away from the arteries now to the third type. Mesenteric venous thrombosis, or MVT, makes up about 5 to 15% of cases.
Yeah, and here the problem isn't inflow blockade, it's outflow congestion. The plumbing is backed up.
Backed up because of a clot in the veins.
Right. This is really a disease driven by hypercoagulability. You have to think about Virchow's triad, endothelial injury, stasis, or a hypercoagulable state itself.
So the risk factors are different here too.
Completely different. You're looking for inherited thrombophilias like factor V Leiden, or acquired hypercoagulable states, maybe associated with malignancy, or things like severe cirrhosis causing portal hypertension, which leads to stasis, even intra-abdominal inflammation, maybe from pancreatitis or diverticulitis, or previous abdominal surgery.
And the clinical presentation for MVT, it's distinct too, isn't it? More subacute.
Definitely subacute, typically. Because the venous system is a bit more forgiving initially, symptoms tend to evolve over days, sometimes even weeks.
Weeks. Wow.
Yeah. You might see prolonged abdominal cramping, nausea, vomiting, sometimes subtle GI bleeding. It's this slower, less explosive onset that unfortunately can sometimes delay the diagnosis. Doesn't always scream vascular emergency right away.
Which brings us to the fourth type. The one you said is often the most insidious and frequently the deadliest. Non-occlusive mesenteric ischemia.
No, my.
No, my. And the crucial point here, there is no physical blockage. No embolus, no thrombus in the artery or the vein.
So what's happening then?
This is really a state of severe systemic failure that results in a regional circulatory collapse in the gut. No MI is caused by intense splanchnic hypoperfusion.
Splanchnic hypoperfusion, meaning blood flow to the gut is just shut down.
Essentially, yeah. It's due to severe generalized vasoconstriction and really low flow states. The body, in a desperate attempt to preserve blood flow to the brain and heart during critical illness, shunts blood away from the intestines. So the context is absolutely critical for no MA.
Everything. This is almost exclusively a disease of the critically ill. You need to be thinking about patients in the ICU.
Like who specifically?
Patients in profound shock, any kind of shock. Patients on high-dose alpha-agonist vasopressors, like norepinephrine or phenylephrine.
Right, because those clamp down on the mesenteric vessels.
Exactly. Or patients suffering from severe heart failure, bad sepsis, or conditions causing high intra-abdominal pressure, like abdominal compartment syndrome.
And the terrible irony here
is that because these patients are often sedated, intubated, or already suffering from multi-organ failure, the usual clinical signs, like pain, are either subtle or completely absent.
That silence is terrifying. The sources confirm NOMAMI carries the worst prognosis of all types, don't they?
By far. In-hospital mortality rates are just staggering, soaring from 58% up to maybe 74%. You're fighting a two-front war, the underlying critical illness, and the resulting gut injury.
And just to be clear for the listener, we need to distinguish all these AMI types from chronic mesenteric ischemia, CMI.
Right. CMI is different. That's purely progressive, symptomatic atherosclerosis, affecting usually two or more major mesenteric arteries, the celiac, SMA, IMA. It leads to those chronic food fear symptoms we talked about with thrombotic AMI, but it develops gradually.
So CMI is more of a chronic quality of life issue, whereas AMI is an immediate life or death vascular crisis.
Precisely. That distinction is important.
Okay, that really sets the stage for the challenge facing the hospitalist. How do you make this diagnosis in time? The classic red flag we're all taught is that sudden, severe abdominal pain that is just grossly disproportionate to what you find on the physical exam.
And let's really dwell on why that discrepancy exists, because it's fundamental to understanding why relying on the physical exam alone is such a trap.
Okay.
Early ischemia, the initial insult, it first affects the mucosal lining of the bowel, the inside layer. That generates pain signals, sure. But the cirrhosis, the outer lining, the part that's really sensitive to touch and contains the nerve endings that trigger peritonitis, is still intact early on.
So the signs we usually look for in a surgical abdomen: rigidity, rebound, tenderness, guarding.
Those only appear when the ischemia progresses all the way through the bowel wall. Transmural infarction. That means the entire bowel wall is dead or dying.
So by the time you can actually palpate peritonitis...
You've almost certainly missed the critical therapeutic window.
Yeah.
You're confirming a dead gut, essentially, not diagnosing an impending crisis.
Oh, okay. So if you wait for those classic signs, it's too late. We have to maintain a really high index of suspicion based on risk factors and the story, even if the patient's abdomen feels relatively benign initially.
Absolutely. And remember the atypical presentations too. Yes, 95% have some abdominal pain, but a big chunk have other non-specific symptoms.
Like nausea and vomiting.
Right. 44% nausea, 35% vomiting, another 35% with diarrhea, and maybe 16% report bloody stool, which can also be a later sign.
And this gets magnified in the ICU setting where no MI is lurking.
Exactly. A sedated or ventilated patient isn't going to complain of pain. Their presentation might be much more subtle.
What kind of subtle signs?
Maybe just some new abdominal distension, or a sudden increase in their vasopressor requirement that you can't otherwise explain. Unexplained metabolic acidosis that keeps creeping up, or even just subtle but persistent vital sign changes like sustained tachycardia or tachypnea. We have to be incredibly meticulous in screening those high-risk ICU patients.
Which brings us, inevitably, to labs. We order them almost reflexively for abdominal pain.
We do, but the sources, especially the recent guidelines, are pretty unequivocal here. Laboratory markers are neither sensitive nor specific for early AMI.
They're just too slow.
They're too slow to reflect that initial mucosal injury. Things like leukocytosis, a rising lactate level, development of metabolic acidosis. These are all late findings.
What do they indicate then?
They indicate the systemic consequences of advanced ischemia, or maybe impending sepsis from bacterial translocation. The key takeaway is a normal lactate level, or a white blood cell count that isn't sky high, cannot, under any circumstances, be used to rule out AMI.
Even D-dimer. Sometimes we think about that with clots.
Yeah, the D-dimer might be elevated. It's usually sensitive, almost always positive if there's a significant vascular occlusion somewhere. But it's uselessly nonspecific, especially in hospitalized patients who often have inflammation, trauma, recent surgery. Lots of reasons for it to be up.
So bottom line on labs.
The reality today is there's no single reliably validated serum biomarker that can reliably detect that initial mucosal injury the moment the clock really starts ticking.
Okay, so clinical exam is unreliable early on, labs are slow and nonspecific. The pathway has to pivot immediately to imaging.
Immediately. We have to transition rapidly to the diagnostic gold standard, triphasic CT angiography.
Triphasic CTA.
This is the mandatory diagnostic tool. It gives us both high sensitivity, somewhere in the 92 to 94% range, and really good specificity, 95 to 99%. But just calling it a CTA kind of undersells it.
Why triphasic? What does that mean practically?
It's triphasic for a reason. It means 3 distinct scans are acquired in sequence, and each phase provides critical, non-redundant information. You need all 3.
Okay, break down those phases for us. What does each one show?
Sure. First, you get non-contrast phase. This helps rule out other common causes of acute abdomen, like kidney stones or maybe pancreatitis, and it detects things like pre-existing calcifications in the vessels or any signs of hemorrhage. Useful, but the real action starts with a contrast.
Got it, phase 2.
Second is the arterial phase. Contrast is injected rapidly, and the scan happens quickly to catch the peak arterial enhancement. This phase is absolutely crucial for spotting the arterial issues, seeing an embolus as a filling defect, or maybe that abrupt cutoff right at the origin of the SMA, suggesting chronic thrombosis.
Makes sense. And the third phase, the portal venous phase, that one's delayed a bit.
Yes, the portal venous phase is acquired later, maybe 60, 70 seconds after injection. This gives the contrast time to circulate through the capillary beds and into the venous system.
And why is that phase so critical?
It's vital for 2 main reasons. One, diagnosing mesenteric venous thrombosis, MVT. You'll see filling defects in the portal or superior mesenteric veins. 2, and this is incredibly important, assessing bowel viability.
How does it show viability?
You look at how well the bowel wall enhances, how much it lights up with contrast. Reduced or completely absent bowel wall enhancement on this phase tells you that tissue isn't getting adequate blood supply. It strongly suggests ischemia.
And you can see late signs too.
Yeah, late ominous signs like pneumatosis intestinalis that's gas trapped within the bowel wall itself, or even gas tracking into the portal venous system. Those usually indicate infarction.
So the absolute imperative here is speed. The second AMI is suspected based on risk factors and that low clinical threshold.
The protocol has to trigger rapid imaging, yes, but also immediate multidisciplinary consultation. This whole diagnostic process needs to be measured in minutes, not hours.
You mentioned thinking of it like an abdominal stroke.
Absolutely. That means engaging vascular surgery, interventional radiology, and critical care simultaneously when you suspect it, not waiting for the CTA report to confirm the disaster is already underway.
Okay, so diagnosis confirmed or highly suspected. Now we jump into the management cascade. The outline says, resuscitate OO, diagnose or revascularize, resect necrosis. Step 1 is aggressive supportive care, focused on perfusion.
Right. Initial supportive management starts immediately. Aggressive fluid resuscitation with crystalloids is key. Sometimes blood products are needed too. The goal is to correct systemic hypotension and optimize visceral perfusion as much as possible.
Because these patients are often really volume down.
Profoundly. They can be third spacing fluids massively or in frank shock. Maximizing systemic flow is really the first line of defense against progressive ischemia while you figure out the specific cause.
And we have to pay excruciating attention to their metabolic state too, right?
Yeah.
Especially electrolytes.
Oh, absolutely. Mesenteric ischemia causes significant cellular injury. Cells die. They release toxic byproducts. Correcting severe acid-based disturbances, particularly metabolic acidosis, is critical, and meticulous monitoring of electrolytes like potassium K+ and sodium Na+ is non-negotiable.
Why potassium specifically?
Ischemia itself, and then especially the reperfusion after blood flow is restored, can cause major rapid shifts in potassium levels. You can get hyperkalemia from cell death, then potentially severe hypokalemia after resuscitation and treatment. These swings can absolutely precipitate lethal arrhythmias.
Okay, what about vasopressors? Many of these patients are sick enough to need them, especially those with no MI, but we know pressors can worsen gut ischemia.
Yeah, that's a real dilemma. Caution is the absolute key word here. Vasopressors, especially the pure alpha agonists like norepinephrine or phenylephrine, cause potent splenic vasoconstriction. They clamp down on the gut's blood supply, potentially making the very problem we're trying to fix even worse.
So what do the guidelines suggest?
Cautious use. Prioritize agents that minimize this effect if possible. If you absolutely must use a pressor to maintain perfusion to vital organs, maybe consider agents with less alpha activity or those with positive inotropic effects. Things like dobutamine, maybe low-dose dopamine, although that's controversial, or milrinone, anything to try and maximize cardiac output without excessively clamping down the mesenteric circulation.
And while the diagnosis is being confirmed and definitive treatment planned, basic systemic support needs to start too.
Definitely. Broad-spectrum antibiotics are crucial. The gut barrier breaks down quickly with ischemia, increasing the risk of bacterial translocation and sepsis. Bowel rest MPO is standard. And nasogastric decompression can help relieve distension and prevent vomiting.
But you mentioned earlier there's been a major paradigm shift in early medical management supported by very recent research.
Yes, the single most important step, backed by the 2024-2025 data, is the necessity of immediate, full-dose systemic anticoagulation. Heparin drip usually.
Now, this is often where people hesitate, right? Especially if the patient might need urgent surgery. There's a fear of bleeding.
There is. But the guidelines are becoming increasingly forceful on this. They state anticoagulation should be initiated as soon as AMI is suspected, unless there's an absolute contraindication like active, life-threatening bleeding elsewhere.
Why is the recent evidence so compelling on this?
Because study after study, including meta-analyses, show a clear survival benefit associated with early anticoagulation across all AMI etiologies, arterial embolus, arterial thrombosis, and venous thrombosis.
And what about that bleeding risk?
The latest analyses specifically looked at that fear. They demonstrated that when it's managed appropriately monitoring PTP or anti-IC levels, having reversal agents available early full-dose anticoagulation does not significantly increase major hemorrhagic complications during subsequent surgery or intervention.
So the benefit outweighs the risk.
Clearly, the goal is to prevent further clot propagation down the mesenteric tree. If we can stop the clot from extending, we preserve potentially viable bowel. The risk of delayed anticoagulation leading to more extensive thrombosis and necrosis far outweighs the manageable risk of surgical bleeding.
That's a really vital, practical point for everyone listening. Do not delay this potentially life-saving step while waiting for the surgical consult or for the CTA read to come back final.
Exactly. Time is bowel. Anticoagulate first, ask questions later, essentially.
Okay, so resuscitation and anticoagulation are underway. Now, moving to definitive therapy. This is dictated entirely by the CTA findings, by the subtype of AMI. Let's start with arterial occlusion, either embolus or thrombosis. The approach here has changed dramatically, hasn't it?
Oh, completely. The paradigm is now strongly endovascular first for suitable patients.
Endovascular first. Meaning what kind of procedures?
Meaning catheter-based treatments. Things like catheter-directed thrombolysis, where you drip clot-busting drugs right onto the clot, or percutaneous mechanical thromboembolectomy, using devices to physically suck out or break up the clot, or angioplasty and stenting if there's an underlying stenosis, especially in the thrombotic cases.
And what's driving this shift? What are the hard metrics from the recent data?
Several things. Endovascular approaches are obviously much less invasive than open surgery. They're associated with significantly lower procedural morbidity and mortality, especially the 30-day mortality rate.
Lower mortality by how much?
It varies by study and patient selection, but some data suggest mortality reductions in suitable candidates by as much as 15 to 20 percentage points compared to historical open surgery cohorts. That's huge.
Wow. Any other benefits?
Yes, and this is crucial. Dramatically reduced rates of eventual bowel resection. Because you can restore flow faster and potentially more selectively, you save more bowel.
Yeah.
And that translates to shorter hospital stays, faster recovery times.
So endovascular is preferred if possible. When do we still need traditional open surgery?
Open surgery is now generally reserved for specific situations. The main one is clear signs of irreversible damage, meaning the patient already has peritonitis, rebound, guarding on exam. That suggests dead bowel requiring resection.
Okay.
Also, patients who are just too hemodynamically unstable to tolerate lying flat in the radiology suite for an endovascular procedure might need to go straight to the OR. Or if the endovascular intervention fails for technical reasons, or if there's already clear perforation or extensive necrosis seen on imaging. In those cases, open surgery is the only path.
Got it. Now, what about mesenteric venous thrombosis, MVT? The approach is different again.
Completely different. MVT is primarily considered a medical disease first. Full systemic anticoagulation, that heparin drip we started earlier, remains the absolute first-line standard therapy. That's usually sufficient to allow the body to recanalize the vein over time.
So surgery is less common in MVT.
Much less common. Surgery is reserved strictly for those patients whose symptoms, like pain or distension, actually worsen despite aggressive anticoagulation and supportive care, or, again, for those who develop clear signs of peritonitis, indicating that the venous congestion has led to transmural infarction.
Okay. And finally, NOMI, that critical care challenge. How do we treat that when there's no specific clot to remove?
Management for NOMI is all about fixing the underlying systemic catastrophe. You have to aggressively optimize cardiac output, improve oxygen delivery, correct acidosis, and critically stop or drastically minimize the use of those offending vasoconstrictors, if at all possible.
Is there anything targeted we can do for the mesenteric circulation itself?
Sometimes. Adjunctive therapy can involve placing an arterial catheter directly into the SMA and infusing a vasodilator, like papaverine. This can help directly counteract that severe pathological splanchnic vasoconstriction that's causing the ischemia.
And surgery in NOMI?
Surgery for NOMI is really only a last resort. It's only required if frank infarction or perforation occurs despite maximal medical management. You try everything else first.
Now, in situations where bowel infarction is present, regardless of the cause, and surgery is needed, the principles of damage control surgery often apply, right?
Yes, absolutely, especially if the patient is unstable or the extent of necrosis is massive. The primary goal initially might just be source control, resecting the clearly dead bowel, maybe leaving the abdomen open and stabilizing the patient physiologically in the ICU.
And this leads us to one of the most critical concepts in AMI management, especially after surgery or even successful endovascular treatment, the planned second-look laparotomy.
This step is absolutely essential. It should be considered non-negotiable whenever there's any uncertainty about bowel viability after the initial revascularization or resection. The guidelines strongly recommend this planned procedure, usually performed within 24 to 48 hours.
Why the mandatory second look? Can't the surgeon tell what's viable during the first operation?
Not always reliably. Reperfusion injury is a complex beast. After you restore blood flow, tissue that looked maybe borderline viable dusky but not black during the first look might do one of two things. It might recover completely, pink up nicely,
Okay.
or conversely, it might deteriorate rapidly due to the inflammatory cascaded metabolic insult triggered by reperfusion. It might declare itself as non-viable only hours later.
So if we rely only on that first look?
We risk two major failures. One, being overly aggressive and resecting bowel that might have recovered, leading unnecessarily to short bowel syndrome. Two, and arguably more dangerous, being too conservative and leaving behind necrotic or borderline tissue that then goes on to perforate later. That leads to delayed peritonitis, overwhelming sepsis, and dramatically increases mortality.
So the second look is really about confirming viability after giving the bowel some time to respond to reperfusion.
Exactly. It ensures you only resect what is truly definitively non-viable, maximizing bowel preservation while minimizing the risk of leaving dead tissue behind.
Okay. Post-operatively, assuming the patient survives the initial event and surgery, intensive monitoring is still required. We're not out of the woods yet.
Not by a long shot. We have to watch very closely for signs of that reperfusion injury we mentioned. It can manifest as a massive systemic inflammatory response, worsening metabolic acidosis, acute respiratory distress syndrome, ARDS, or new onset of multi-organ dysfunction, like kidney injury.
So ICU care is standard.
Intensive care management is absolutely standard after any significant mesenteric ischemia event.
Let's talk prognosis again, the hard numbers, because even with all these advanced techniques and protocols, the reality remains pretty harsh, doesn't it?
It does. Overall mortality is still high, often cited in that 50 to 60% range globally. But as we discussed, the prognosis varies massively depending on the subtype.
Remind us of that range again.
Mesenteric venous thrombosis, MVT, generally has the best prognosis. Mortality there is usually quoted between 13 and 25%. Again, likely due to its more subacute nature and good response to anticoagulation if caught early.
And the worst.
NOMI. Non-occlusive mesenteric ischemia remains the deadliest by far. Mortality rates are consistently reported between 58% and up to 74%. It's just incredibly difficult to manage.
And predictors of survival. Unsurprisingly, it all comes down to time.
Time is everything. Delays in diagnosis, delays in getting that initial hospital-based consultation, or critically, delays in achieving revascularization, whether endovascular or open, are the biggest drivers of poor outcomes. They directly correlate with increased mortality and the likelihood of needing life-altering extensive bowel resection.
Are there any positive predictors, things associated with better outcomes?
Yes. Procedural management matters. Patients who are able to be managed with endovascular approaches generally tend to fare better, likely due to less physiologic stress. And certain CTA findings, like seeing some persistent, even if reduced, bowel wall enhancement on that portal venous phase, suggest at least some tissue viability remains, which is a positive sign.
Beyond the immediate risk of death, the complications for survivors can be absolutely devastating.
They can. Immediate risks, as we touched on, include overwhelming sepsis and multi-organ failure, often driven by that bacterial translocation across the compromised gut barrier.
And the long-term consequence that hangs over survivors.
The major one is the risk of short bowel syndrome. This happens when extensive resection is unavoidable, leaving the patient with insufficient intestinal length to absorb nutrients. It often requires lifelong dependence on intravenous nutrition, PPN.
Which really underscores why that focus on endovascular methods, trying to save bowel, and that mandatory second-look laparotomy are so critical. Saving every viable centimeter counts.
Absolutely. It's not just about surviving the acute event. It's about preserving quality of life afterwards.
And just to circle back one last time on anticoagulation, because it seems so counterintuitive in a potential surgical emergency. The growing confidence in using full-dose anticoagulation early.
It's a major advance. The accumulating evidence showing it does not significantly increase hemorrhagic risk when managed appropriately is really key to changing entrenched hospital behaviors and overcoming that initial hesitation.
Okay, so we've covered pathophysiology, diagnosis, management of the individual patient. But you mentioned earlier, improving these notoriously poor outcomes requires more than just individual clinician knowledge. It requires system change.
Yes, here's where it gets, I think, really interesting and potentially transformative. To truly move the needle on AMI mortality, we need institutional commitment to standardization. We need complex, time-sensitive care bundles, clearly defined clinical pathways, and a very high degree of seamless multidisciplinary coordination.
The sources specifically mention the concept and implementation of specialized intestinal stroke centers. That sounds powerful.
It is. It's arguably the ultimate systemic solution. If we truly treat AMI exactly like a cerebral stroke or a heart attack as a thymus tissue vascular emergency, then it makes sense to centralize expertise.
And what does the data show from these centers?
The data emerging from institutions that have implemented this model shows they can dramatically reduce diagnostic delays. They achieve higher overall rates of revascularization, particularly using the preferred endovascular approaches. And, most importantly, they demonstrate lower mortality rates compared to non-specialized care.
How do they achieve that?
It forces everyone, emergency medicine, radiology, vascular surgery, interventional radiology, critical care, hospital medicine, to operate synchronously from the moment of suspicion. It breaks down those traditional departmental silos that often cause delays.
But that raises a huge practical challenge, doesn't it? Many of our listeners work in community hospitals. They might not have 247 interventional radiology or dedicated vascular surgical teams on site. How do the guidelines address transferring these incredibly unstable patients?
That is the absolute critical question, and it comes down to resource allocation and pre-planning. If the specialized center model truly offers the best chance for survival, then community hospitals must have clearly defined, well-rehearsed, pre-activated transfer protocols for suspected AMI.
So the transfer clock starts immediately.
The moment high suspicion arises or the CTA confirms the diagnosis, yes, the transfer clock has to begin ticking. The initial stabilization steps, fluids, antibiotics, and that crucial immediate anticoagulation must happen locally, rapidly. But definitive treatment, especially complex revascularization, often requires rapid movement to the specialty center, even though the patient might be inherently unstable.
That's a tough balance. Stabilize versus time lost in transit.
It's an incredibly difficult balance. The challenge is minimizing time to definitive revascularization. Every hour counts.
Which puts immense pressure back on the hospitalist, the ED physician, the first responders to recognize it instantly, start the initial management, and overcome the inertia that can sometimes bog down transfer protocols.
Yes. The whole point of having a protocol is to standardize the response and override individual hesitation or system friction in these high-stakes, low-frequency events.
Okay, so let's try to summarize the absolutely essential takeaways for you, the listener, working in the hospital. First, maintain that incredibly high index of suspicion. If the patient has risk factors, AFib, vascular disease, critical illness, and abdominal pain that just feels off or disproportionate to your exam.
You must initiate the AMI workup immediately. Don't wait.
Second takeaway.
Do not rely on or wait for lab markers to rule it out. Leukocytosis, rising lactate, these are late confirmations of advanced disease, not early diagnostic tools. A normal lactate means very little early on.
Third, imaging.
Imaging is key. The diagnostic gold standard is triphasic CT angiography. And you need to ensure or understand that all three phases, non-contrast, arterial, and portal venous, are obtained and reviewed carefully, looking for both the vascular occlusion and, critically, assessing bowel viability based on wall enhancement.
And finally, perhaps the most impactful early intervention you can initiate.
Immediate, full-dose systemic anticoagulation, usually a heparin infusion. It's mandatory for suspected arterial and venous causes, unless absolutely contraindicated. The evidence strongly supports that the survival benefit outweighs the manageable risk of surgical bleeding when it's monitored appropriately. Don't delay it.
So, high suspicion, rapid CTA, early anticoagulation. Those are the pillars.
Those are the immediate action items, yes.
Now, for a final provocative thought, you raised this idea of intestinal stroke centers. If centralizing care for this complex, rare, high-mortality condition dramatically improves outcomes.
Yeah, it makes you wonder, doesn't it? What other rare, high-mortality hospital emergencies could benefit from similar dedicated, standardized care bundles and rapid response teams? We spend enormous energy optimizing care for common conditions like pneumonia or heart failure, which is important. But maybe the greatest marginal gains in mortality reduction are now to be found by rigorously standardizing the care of these rare but devastating conditions.
Like massive PE response teams or sepsis bundles, applying that same coordinated, time-sensitive approach to AMI. It really requires hospitals to rethink their operational structure around all time-sensitive vascular events, regardless of location, brain, heart, or gut.
It does. And it leaves that community hospital, the referring hospital, with that agonizing challenge.
Yeah.
What is the most efficient, safest way to manage the ticking clock for a patient who is already crashing, knowing that the definitive revascularization capability might be hours away by transport?
That decision, stabilize more here versus transfer immediately, might be the hardest call a hospitalist has to make in these situations.
It truly might be. There's often no perfect answer, just the least bad option driven by the protocol and the local resources.
Well, for those listeners looking to dig deeper, to actually implement these life-saving protocols and care bundles in their own institutions, we strongly recommend seeking out the World Society of Emergency Surgery guidelines. They are very comprehensive.
And also look at the recent 2024 and 2025 research papers we alluded to, especially those comparing outcomes between endovascular and open management. That evidence really forms the foundation of modern practice in this incredibly high-risk field.
It's clear that while AMI is rare, being prepared and having a system in place is absolutely critical.
Couldn't agree more. Preparation saves lives here.
Thank you so much for joining us for this deep dive into acute mesenteric ischemia.
My pleasure. Important topic.